think it's important to think. Okay, right. And I think it's important to start thinking about what is the future of surgery or oncological surgery, because things are going to change through your career. There has been a lot of changes through my career, but in the next 20, 30 years, there'll be loads and loads of changes. We'll spend a bit of time, just some advice on going into surgical training and what I think you should remember and not forget. And then if time permits, we'll talk a bit about whether there is still anything called general surgery. The training in surgery is still very much general surgery, but we'll discuss that. And then if we do have time, I'll discuss an interesting case. So if we go on to the next slide, please, Sabira. Right, okay. So during my pre-university days, so i.e. when I was growing up and in school and so on, I was very interested in neurosurgery, and that is very much what I wanted to do. Obviously, being a kid, I didn't really know much about neurosurgery. And then later on, I started thinking about cardiothoracic surgery. Some of you may have heard about a South African cardiothoracic surgeon called Charles Barnard, who in 1969 performed the first cardiac transplant. So that was a huge thing at that time. So when I was in school in the 80s, I started to read about about Barnard, and I really wanted to do cardiothoracic surgery. And then I started thinking about all sorts of other things, including physics and engineering and law and all sorts of nonsense, as you normally do. And then eventually decided that what I did want to do was back to neurosurgery, but predominantly an interest in spinal injuries. So I applied to Liverpool Medical School. I went to Liverpool, wanting to do neurosurgery. So went through my university days and tried to expose myself to as much surgery as I could. And in those days, the format was very, very flexible. So you could just go and meet people up, go into different hospitals, go into theater, and do all sorts of things. It's a bit more difficult now for various reasons. But I then went on to basic surgical training in Manchester, still wanted to do neurosurgery. But whilst I was actually doing neurosurgery as a senior house officer, which is what we were called at that time before core training, I found that the radiologists were having all the fun, and neurosurgery was really very much a dying specialty. So I then started thinking about vascular surgery. And this is where I was saying about things change all the time. So don't put all your eggs in one basket, because what you might want to do now may change in a few years. Now, during my time, it was impossible to get into higher surgical training without having done any research whatsoever. So I ended up doing a 2-year research degree, and it so happened that it was in colorectal. I had no interest in colorectal prior to that. As I said, I was thinking of vascular surgery, but I was forced to do a colorectal research job simply because they had an ongoing project, and the ongoing project was a colorectal project, which the previous person hadn't quite completed. So I had to take it over and try and carry that forward. So almost inevitably, I had to say that I wanted to be a colorectal surgeon, and therefore went into higher specialist training, wanting to be a colorectal surgeon. Whilst I was doing colorectal surgery training, halfway through, I then changed back to vascular. And then I realized that once again, the radiologists were having all the fun, and vascular surgery was very much cell-based surgery and was really not very interesting anymore. So I then switched back to colorectal. And I eventually became a consultant in North Wales, with a predominant interest in inflammatory bowel disease, as well as advanced oncological surgery, advanced rectal cancers, and mostly laparoscopic. So we go on to the next slide, Vera. Right. Okay. So what is involved in colorectal oncological surgery? It is very much a multidisciplinary approach. I worked with lots and lots of different people and different specialists. I had a dedicated colorectal radiologist. So we used to have multidisciplinary meetings with the radiologist, discuss cases, especially since I was doing mostly advanced cancer cases. Obviously involved with pathologists, because one of the interesting things that you find with colorectal surgery is certain conditions can actually masquerade as a cancer. The commonest being advanced diverticular disease. So you can get diverticular disease complications. You can't tell the difference on a scan, on a CT scan, between a cancer and diverticular disease and benign disease. And some of these things you can't actually get to biopsy. You may know that the gold standard is to do endoscopy to get biopsies from bowel cancers, but sometimes it's just not possible. So some of these challenging cases, we have to assume that they are a cancer and do essentially a cancer operation, and that's what we discuss with a patient. And then if it turns out to be completely benign, then it's a bonus. But at the end of the day, we've still done a cancer operation. So pathologists is where they come in. They might see the biopsies beforehand and let me know whether, yes, this is definitely a cancer, and therefore the patient is suitably consented, or otherwise they tell us, especially the biopsies are negative, not sure whether it's a cancer or not, but we treat it as a cancer. Oncologists obviously get involved after the surgery with chemotherapy and radiotherapy, but quite often we do give preoperative chemotherapy and radiotherapy, especially to advanced rectal cancers. Unfortunately, we sometimes have to involve palliative care, as in the surgery is irresectable, inoperable, or patients get recurrence and metastases, not responding to chemotherapy, etc. Gastroenterologists diagnose quite a lot of the cases for us, since they tend to do most of the endoscopy. We also involve geneticists, especially with certain types of bowel cancers, especially in young patients. We have to do family screening, look at family history, etc. With the sort of work that I was doing, I involved lots of other surgeons because we were dealing with rather complicated cancers. So very often I had a urological surgeon or a gynecologist in female patients, vascular quite often, because I'll do a pelvic lymph node clearance, and sometimes if it's an advanced cancer involving the iliac arteries, doesn't need to involve the vascular surgeons. It's quite common for us to tie off the inferior iliac, internal iliac artery, which you can easily do, but obviously you can't do that to the external iliac because then the leg will lose its blood supply. So I've had cases where I've had the vascular surgeons remove the external iliac and internal iliac, or even the common iliac, together with a specimen, and then they'll graft across to maintain blood flow to the leg. Sometimes we even involve orthopedics if parts of the pelvic bone is involved. I've had cases where I've been involved with ENT surgeons and maxillofacial surgeons, but it's generally ENT and maxillofacial cancers rather than colorectal cancer, where they quite often do a throat resection, and we pull up some small bowel or large bowel to perform a graft as a conduit. Rest of the team, specialist nurses, they're absolutely invaluable, because these are people who keep the communication going between the medical team and the patients, because quite often, we only have half an hour, 40 minutes to talk to a patient about what you're going to have done, and then it's the nurses who pick up the pieces afterwards, because they almost always never break down in front of me, but they definitely break down in front of the nurse, especially when they had no idea whatsoever that something could be a cancer. Got a theatre team, of course, anesthetics, especially with the long, difficult, complicated cases, need to have experienced anesthetics. I used to have a theatre assistant who was a nurse, and she was trained to work with me to do some of the advanced laparoscopic work. senior scrub nurses, and we have nurses who run around and other healthcare staff who run around, get equipment, and so on and so forth. Now, wards, patients go quite often to high dependency unit or intensive care afterwards. So obviously nurses, healthcare assistants, and physio extremely important post-surgery as part of advanced recovery. And these patients who've had abdominal surgery are at risk of chest infections. So the physios work on your chest, make sure they're breathing properly. And we do lots of things, mobilize them, get them up and about as soon as we can, etc. Anyone else? Other people important? Absolutely, my secretary. She's brilliant. She deals with the patients, especially when they keep calling, wanting information. So she organizes everything. Got our admin and management staff who organize the theatre lists and so on and so forth. And especially I need to opt through the evening, etc. For a long case, or some case we actually operate over 2 days. Not continuously, obviously. We obviously take a break, patient goes intensive care and then comes back to theatre. So admin will then have to change my sessions around, move my clinics around, etc. And porters, yeah, they bring things, they take specimens across and so on. Next slide, please. Okay, now what I think is the future of colorectal or essentially surgical oncology in the future. As I alluded to previously, and I said previously, lots of things have changed through my career, and even more advances will be made in the next 20, 30 years. The role of screening, we're now screening bowel cancer, and we're now picking up cancer at either a very early stage or at a pre-malignant stage. There's something called the polyp adenoma sequence, where bowel cancer we know starts off as a polyp, and whatever the time duration may be, generally between 7 to 10 years, polyp, not all of them, but some of them, then acquire genetic changes and then go on to become a cancer. In some of the genetic conditions, this is accelerated, and that's where family history screening comes in, and genetics, which is the next bit there. But then the whole idea of screening is to pick up these polyps whilst they're still benign. So I think what will happen is the incidence of bowel cancer will reduce, and colorectal surgeons like myself who've been dealing with bowel cancers will have a lot less work to do. And specialty changes all the time. Genetics, as I said, there is a genetic basis to cancers. We know that roughly 5% is definitely genetic in origin. There's about 50% of bowel cancers where we think there's a genetic predisposition of some description, and that was one of the research topics that I looked at when I was doing my research. But some of these genes are not clearly identified yet, and things will change with time. Immunology, we know immunology plays a big part. We know that some patients with seemingly advanced cancers do well, and there are some patients with seemingly pretty straightforward, fully resected cancers who don't. And clearly the immunology has got something to play with this. And interestingly, I actually think that we've learned a huge amount of immunology from COVID. And in the next decade, 2 decades, medicine itself will dramatically change, let alone surgery, because genetics and immunology will play a huge part. Radiology and interventional radiology is already taking over quite a lot of cancer type work. As I said previously, neurosurgery, the neuroradiologists are getting much better results than neurosurgeons generally with many types of brain tumors. And now in colorectal surgery, in the last 5 years, we have been operating on less and less rectal cancers. I think some of this is due to the screen program. Some of this is due to the awareness among the general public and general practitioners and so on. Some of it is due to the referral patterns put in by NICE guidelines and so on. But I think things are actually changing, and we're now in many rectal cancers following an MR scan and CT scan staging, etc. These patients are getting preoperative chemoradiotherapy, and we're finding that some of these patients are actually getting cured. As in, when we actually go ahead for an operation, we find that there is absolutely no residual cancer left in the original specimen, and is all scarred up. So what we are starting to do at the moment, and this will change in the future, is what we term or consider younger patients will still go on to have a full traditional cancer operation even after preoperative chemoradiotherapy, and when the subsequent biopsies are dead negative. As I said, quite a lot of these patients, we are still we find that the cancer is completely cured, but we are still operating on them simply because we haven't got enough long-term data yet. Now, the older patients and the higher risk patients, we're not operating anymore. If they've had biopsies following preoperative chemoradiotherapy showing that there is no residual cancer, we're just adopting a wait and watch policy. And I think as we gather more and more data over the next 5 to 10 years, certainly rectal cancers will decrease. And there's a lot of suggestion now that rectal cancers, as opposed to the rest of the bowel cancers, is genetically and immunologically slightly different, and they do behave differently. We're now doing much more minimal access surgery. Gone are the days when patients had horrendous scars across the abdomen with horrible recovery times, and some of them just never recover from it. Now, with some of the minimal access surgery, patients are back to driving and mowing the lawn, etc., within 2 weeks. There was a patient of mine some years ago, and that, to be fair, it was a relatively straightforward cancer. Operated laparoscopically. He went home day 4, and apparently 10 days later he decided to mow the lawn, and he was fine. And 2 weeks he was driving. And when I saw him in clinic, he looked like he didn't have an operation at all, and that's what keyhole surgery, laparoscopic surgery is doing. TEMS is a technique of operating on early cancers and large polyps through the anus. And some of the polyp cancers, we're now removing them endoscopically through a colonoscopy and not necessarily needing a full operation. Robotics, you've come across robotics, surely. You might have seen some robotic surgery. It's not actually a robot operating, it's actually a surgeon manipulating a robot. And it's the next stage after keyhole surgery. It's essentially more advanced keyhole surgery. For colorectal surgery, there's no real evidence that robotic surgery improves outcomes. In fact, some of the initial data actually suggested that outcomes were worse, but we think it's because of the learning curve. What robotics does provide is absolutely phenomenal views of the surgical field. And it's very good in preserving function, because one of the things that tends to happen with rectal cancers is we end up destroying some of the pelvic nerves, which causes impotence in males and all sorts of bowel dysfunction. And sometimes, even though we anastomose and join up the bowel afterwards, your function is so bad, they come back to us and say, look, I'm having diarrhea all the time, or I'm incontinent, and can I have a bag, please? And have a colostomy instead. But with robotic surgery, the views are so good that we can actually preserve these nerves. It is, of course, difficult to do so in advanced rectal cancers. The future, I put on the semi-autonomous robotics. It's not here yet. I think it is the future, not necessarily in colorectal surgery, but in some other fields of surgery, maybe things like orthopedics. You could have a situation where a robot semi-autonomously does the operation or some of the operation. And don't forget, with robotics, and you can attach all sorts of sensors, which we don't have as humans. where robotic surgery has really made a huge difference is in prosthetic cancer. The outcomes are so much better with robotic surgery, both in terms of cancer survival, in terms of reduced recurrence, as well as, more importantly, function afterwards. But I think what we're going to end up left with is salvage surgery. At the end of the day, we're still going to need surgeons. There's what I mean by salvage surgery is when either patient has somehow not been picked up at an early age, or comes in as an emergency and not able to use all these other methods, radiological or robotic or keyhole surgery, or immunological treatments, and so on and so forth, and then you just have to do some salvage surgery. Next slide, please, Sabira. Okay. I think anything else from surgery, I thought it'll be best that we leave it as Q&As, because you'll have lots and lots of different questions, and we can explore it as it comes. But some pieces of advice. I think in any field of medicine, be it surgery, whatever, I think there are two questions to ask, and this was said to me on my first day in hospital medicine, in a hospital in Liverpool, and this was towards the end of my second year, because it was the old style system where you didn't really get introduced to hospitals and patients until later on. And the consultant who sat with us said you should always ask two questions, and I think this is what I say to all my juniors and everyone else. The first question, and most important, I think, is you've got to ask whether you're prolonging life or death. Now, this is especially important in emergency surgery, but it's also important in cancer surgery. Yeah, I've operated on a 101-year-old who was actually very, very healthy and very, very fit. And I was certainly prolonging life. And she got, it was completely curative surgery. And she died when she was 106. And until she died, she was shopping on her own and driving. I know it's scary thinking of a 106-year-old driving, but she was. So in her case, I think we prolonged life. But there are some people even in their 60s who might be so unfit that putting them through surgery, the anesthetic and the stress of surgery, would have probably killed them earlier than their cancer would. So that's the sort of thing to think about. And obviously in emergency surgery, it's a different ballgame altogether. So ask the question: are you prolonging life or death? The second thing is, I think this is very, very important, is what would you have done if this was your father, mother, brother, sister, husband, wife, etc. Because just because we can do something and operate doesn't mean we should. You should think whether this is the appropriate thing to do, or what the appropriate treatment might be. Surgery is not always a treatment of choice. There are alternatives, and it's important to consider those alternatives. Now, something else to think about, not so much when you're medical students, but when you start working, is make friends. Make friends at every job, and flowers and chocolates go a very, very long way. Always make friends with a sister or charge nurse on the ward. Whatever you end up doing, surgery, medicine, whatever, they'll make life so much easier for you if they like you. And one way to get them to like you is a very simple bribe. Another person always is the boss's secretary. Remember, the boss's secretary is the one who actually does your reference, because the boss will just dictate a reference and the secretary will type up the reference. A bit different with structured references now, but generally it's the secretaries who do the hard work. So if the boss thinks that you are great because you know how to work your way around the boss, but the secretary thinks you're completely useless and said all sorts of other things, the secretary might just have a quiet word with the boss and say, do you really think this person is so good as you think? I don't think they are. Or if you haven't really impressed the boss, because you hardly see the boss, or you're the sort of person who works in the background and doesn't really show off that much. The secretary might then put a quiet word to the boss and say, hey, you know what, you're giving a pretty ordinary reference, but this boy, this girl is actually very, very good. They sort everything out. Very quiet, but get everything sorted. So the secretary will definitely change the reference. Something else I think is quite important is go and see other subspecialties, not necessarily just surgical, if you're interested in surgery, but other things. Pathology, radiology is a good one. I had the opportunity, and I made sure I looked at different specialties, and as I say, kind of jumped between specialties. But I did gain a huge amount of experience and saw lots and lots of different things. I've clearly adopted these different things in my practice. There are certain things in neurosurgery that I was doing colorectal surgery, believe it or not, but it was just techniques. I've worked with the ENT surgeons or max fac surgeons and seen some of the things they do. Orthopedics, not so much, but that's another thing. But there are certain things in orthopedics. Look at radiology, because you might find that radiology might be a better field for you, depending on your personality, depending on your life circumstances, etc. Because at the end of the day, even though surgery is a lot more family-friendly and a lot more work-life balance type of specialty than it used to be, it's still quite hard work, and you may not necessarily want that because life changes. But I think one of the most important things is always have a plan B, C, or even D, and do not lose hold of your hobbies and interests. I know so many people who've gone into surgical training and have completely given up music and this and that. I've known people who were concert level pianists, and they completely stopped playing the piano just because there was so, the usual excuse or the usual difficulty is, don't have enough time. You should find the time. Some people will tell you, no, you should put all your eggs in one basket, concentrate, try to be the best at what you can be, and forget everything else, because if you're not focused on what you want to do, you will not succeed. I think that's complete nonsense. I think having different interests and different plans, yes, you could get a bit distracted, but you've got to be disciplined. But I think what it does give you is it gives you a better perspective. And I've had trainees with me in surgery who are fine, with their hands, and who can operate, but they can't talk about anything else, and it becomes extremely boring in theatre, because they just can't talk about anything. Can't talk about cricket, can't talk about football, this, that. You want to be able to talk about different things. Right. How are we doing for time, Abira? I suppose we're okay for time, are we? Should we go on to the next slide then? Okay, I think it's useful to see what's happened with general surgery, or what is happening with general surgery, and how I think things are going to change in terms of training and specialty. We still consider general surgery as a specialty, and certainly training is still considered general surgery, and GMC still considered specialist registration in general surgery, not as a specialty. But I don't think general surgery really exists anymore. Now, in the old days, a surgeon did everything. Anything that involved the knife and stitching was done by a surgeon. Gynecology split off many years ago, many years before my time. And it's a completely different training program altogether. The exams are completely different. What they need to know about anatomy is completely different. Orthopedics also started splitting off, although even up to the late 90s, there were hospitals in Ireland and Scotland and in Wales where the general surgeon was still fixing hips, the fractured necks of femur, and so on. The elective sort of hip replacements were usually not done by general surgeons anymore because that split off. They'll go off to a different hospital. Urology split off as a separate training and separate specialty in the early 90s, and vascular essentially became a separate specialty for training about 4 or 5 years ago. But vascular surgery still has some overlap with general surgical training in the earlier. So in the first 2 to 3 years, you still do some general surgery before you start specializing in vascular surgery. In training in general surgery, you start with what's with various fields, so you'll have various attachments, and then you'll start subspecializing. And the main specialties are colorectal, upper GI, which is both benign and oncological. But upper GI is very much split now in many units, where there are some surgeons who just do benign work, although the oncological surgeons will do some benign work, but generally the oncological upper GI surgeons have work in their own central units. Hepatobiliary surgery also split off some time ago, and it's got a combination of both cancer work as well as benign work. And the benign work tends to be mostly dealing with complications following gallbladder surgery, laparoscopic gallbladder surgery. The cancer work is predominantly liver resections for bowel cancers. Pancreatic cancer, some of it is still operated, but more advanced ones are more difficult and to be more palliative. Breast split off from general surgery was essentially combined with endocrine surgery, because at one point there wasn't enough work in breast surgery or endocrine surgery to split them off as two separate specialties. But breast is now going more towards plastics, and they're getting very little experience with general surgery or with emergency surgery, that it will almost certainly split off into its own specialty and probably more plastics as there's more reconstruction. Breast is still part of the general surgical training, but it won't be for long. Endocrine surgery is interesting. As I said, it was previously combined with breast surgery, but it's now a separate specialty. But then a lot of the work has been removed, as in thyroid surgery is now very often done by the ENT surgeons. Salivary gland surgery tends to be done by the maxillofacial surgeons. Endocrine surgeons generally did not deal with the pancreas anyway. It was done by the HPB surgeons. They used to do quite a lot of adrenal surgery for adrenal tumors, both benign and cancers. But that has now gone the way of urology, because the urological surgeons have been doing laparoscopic nephrectomies, so they're now doing laparoscopic adrenalectomies. So endocrine surgery per se is splitting off and will, or rather split off and will disappear. Pediatric surgery is probably still very much general surgery. They do all sorts, but then you do get subspecialist pediatric surgeons, subspecialist pediatric colorectal surgeons, subspecialist pediatric HPB surgeons. You can get quite a lot of interesting things with hepatobiliary surgery in children. Next slide, please. So what is left is general surgery? Well, abscesses, very common. But having said that, breast abscesses are now being dealt with by breast surgeons, and quite often by minimal access. Gone are the days when breast abscesses used to get a huge slash. When I first started training, I was told that you should make a big cut to drain the abscess, and you can imagine the cosmetic result afterwards. It was just horrendous. Now it's minimal access, usually with a needle, and then antibiotics, etc. So it's very, very unusual now to actually operate with a knife on the breast abscess. But it's now almost always dealt with by breast surgeons because it's not something that needs to be done in the middle of the night. Anal buttock abscesses are still done by general surgeons, but then some of these can get quite complicated. And I personally think it's better off being done by colorectal surgeons. I've lost my slide. Vera?
Sorry, just my internet connection. I'm just uploading it again.
Okay, it's okay. I'll stop. I'll just carry on talking. Oh, great. Okay, scrotal abscesses are now dealt with urologists, simply because some of them can be quite complicated. Something called Fournier gangrene, which you may or may not have come across. I won't talk more about it, but they are pretty nasty. Groin abscesses used to be pretty common as well. Don't see as many as we used to. Mostly tend to be in the intravenous drug abusers, and is now dealt with by vascular surgeons mostly, because quite often there's involvement of the femoral artery or vein with this. The non-drug groin or axillary abscesses is now tends to go to plastics, simply because the underlying cause is a condition called hidradenitis suppurativa. May or may not have come across that, and that's now being dealt with plastic surgeons. Appendicectomy, still very much mainstay of emergency general surgery. Most of it is now laparoscopic. Something else that is still left as general surgery is abdominal wall hernia. So there's things like inguinal hernias, femoral hernias. One of my specialist interests is complex abdominal wall reconstruction for massive hernias. But this is a consequence of my advanced cancer work, because some of my cancer work actually involves removing part of the abdominal wall. Gallbladders is a very, very common operation. So this is pretty much what's now left in general surgery. Okay, do we have time for a brief chat about my okay, if you just go on to the next thing. Yeah, okay, just something a little bit about emergency general surgery. As you've seen, was there in the previous slide is very much what comes in as the emergency general surgery take now. Acute gallbladders, which so patients with cholecystectomy, we try now to deal with their gallbladder during their index admission, rather than the old days we used to treat them with antibiotics, send them home, and then bring them back. But with waiting lists and so on, they ended up having complications and lots more problems. So we try and operate on that index admission. A lot of the basic general surgery now do not require surgery. They can be dealt with antibiotics, or commonly non-specific abdominal pain. So there's less and less surgery now. And as we are doing more and more scans, we are avoiding surgery. In the old days, quite often any abdominal pain was operated upon. Most of the time it was what we call a negative laparotomy. You open the abdomen and there's nothing wrong. It's just non-specific, bit of wind. Okay, I'm exaggerating, but it's very unusual now for us to operate and not find something, because we tend to do CT scans. Some of the abdominal abscesses and things can be dealt with a radiologist with drains, and sometimes this is a far better way to deal with things, simply because things are so inflamed that they can be quite difficult. And some of the appendixes can be quite difficult to operate, and sometimes you're just better off dealt with a drain, let the badness out, let the muck out, let things settle down, and then bring the patient back for a planned operation. There's a concept called damage limitation surgery, and this all really started from the Gulf War and Afghan wars, where in the old days, emergency surgery, we tried to do everything in one go, and it didn't work very well. And what they found in the battlefield was we tried and save these soldiers being blown up and so on. Spent 6-8 hours in theatre, which meant that didn't have a chance to operate on anyone else. And these soldiers inevitably died simply because it's the response to trauma. So what we do now is quite often is damage and mutation surgery, where we deal with bleeding or we deal with contamination. There's perforated bowel. We just staple off that bit of perforated bowel and just leave it stapled. And then patient goes back to intensive care with essentially an open abdomen. We put a temp dressing on it, and then usually in 24, 48 hours later, when they are a lot more stable, so you've got fluid on board, antibiotics on board, you've dealt with your chest, your heart, etc., etc., and then we do a proper operation, and we found that our survival rates have increased tremendously. Do we need subspecialist surgeons for emergency general surgery? I don't think so. We train people to be colorectal surgeons and hepatobiliary surgeons. Training issues, costs, waiting lists, and there is a realization now that some of this subspecialist surgery should be subspecialist, as in get trained to be emergency safe, to be able to deal with emergency surgery, and then everything else can be dealt with by the subspecialists. Next. Okay. Okay, that's interesting. Right. Okay. Unfortunately, I can't show you any pictures because of patient confidentiality, etc. But there was an interesting case I was involved with. Something very common was thought to be appendicitis. Remember, I said thought to be appendicitis. So there was this chap in his early 30s. It's a bit plump, completely fit and well. I can't remember what he worked as. I think it was a HGV driver. And he came in on the emergency take under one of my colleagues, and straightforward, short history, absolutely consistent with appendicitis. You know, that's what you expect in someone of his age. No previous history of anything else. So he had tendon in the right left fossa, guarding localized peritonitis. So a classic textbook example of appendicitis. So my colleague left our trainee registrar, quite good trainee registrar, completely capable to start the case, and almost inevitably other things happened in theatre, blah blah blah. So it was something like 10 o'clock at night that he got to theatre, and our standard now is to do keyhole surgery. So put a keyhole in, put a laparoscope in, had a look. There's contamination in the right left fossa, with some pus and muck and things, and he couldn't really see the appendix, and this is quite common. This happens, especially with a nasty appendix. So he fiddled around a bit, and then he realized that okay, maybe a bit over his head, therefore needed to call the boss in. So boss came in, colleague came in, obviously wasn't very pleased because by now it was nearly midnight. Went in, and yeah, okay, it's pretty nasty appendix. So he dealt with it quite appropriately, took the appendix out, washed it all out, but because of the lot of contamination, left the drain in. And fine, patient made a recovery, was fine, was in hospital for a few days, which is a bit unusual, but because it was quite nasty, it wasn't unexpected. Treated with antibiotics, and he was fine. He had the drain taken out. He was well enough to go home and went home. Histology, so appendix, we set, so as routine, anything that we take off, we send to the pathologist to have a look, and occasionally you get a nasty surprise. In this case, it was straightforward. Yep, appendicitis, nothing else, absolutely fine. And then I think it was some months later, this patient came back in under a different consultant, a different league, and he had abscess just where no, sorry, my colleague actually did an open appendicectomy. because found that it was a bit complicated, so didn't open the appendix. So when this chap came back in, I think something like a few months later, under a different person, he had an abscess just underneath his skull. It happens because sometimes you get a collection where the appendix has been removed, sometimes leaks. So then forms a tract to the abdominal wall. It's not common, but it's not rare either. You do see it occasionally. So quite reasonably, this was patient went to theatre, had a drainage of the abscess like any other abscess, dealt with it fine, and fine. And then some months later, he came back in under a different consultant this time, because we've got different people doing different on calls. You don't necessarily hand over relatively straightforward cases to other people. If it's a bowel cancer patient comes in as an emergency, then for whom I've operated on will then come back to me, for example. But anyways, relatively straightforward cases like this, it's dealt with by different people. So once again, okay, recurrent abscess, okay, not uncommon, but slightly unusual, but not uncommon. So patient went to theatre to have this drainage, and whilst the patient was in theatre, it was actually my registrar who was on call, and I wasn't, but my registrar called me and said, boss, I'm a bit concerned about this. This is a bit unusual. Can you just come and have a look? I know you're not on call, it's not your patient, but I think you need to have a look at this. I went to have a look at it, and I thought, okay, yes, definitely a bit unusual. It didn't look right. So I drained it, but I took some tissue off and sent it off to the pathologist. And lo and behold, it came back as a bowel cancer. This does happen occasionally. So remember, this chap's in his early 30s. So he then became my patient, and we did a CT scan, staging scan, and he had a very, very advanced cecal cancer, which had now clearly perforated, hence the abscess was now involving the abdominal wall, both on the front and to his side, as well as his retroperitoneum and his kidney. But there was no metastatic disease. So he then became my patient, and we then discussed what we needed to do, which was going to be a very complex operation. So we did a very complex operation. So he had what we normally would do for this is a right hemicolectomy. So remove the right side of the large bowel. And basically what had happened was he had a cecal cancer which had blocked off the appendix. So the appendix had then become inflamed because of the cecal cancer, but the appendix itself was normal. So yes, he did have appendicitis, but it was secondary to something else. So one of our policies now is when we get older patients with appendicitis, we actually do a colonoscopy to make sure they don't get a cecal cancer. And we've had 2 patients since whom we have picked up a small cecal cancer causing the appendectomy. Anyway, with this chap, so I had to take off most of his anterior abdominal wall, the right side of his abdominal wall, his kidney, his ureter, some of the silver muscle. Managed to preserve his femoral nerve, but the lateral cutaneous nerve of his thigh had to be sacrificed. But there was no involvement of the iliac. I then reconstructed his abdomen with porcine dermis, and thankfully he had enough fat and skin to cover. And he made a full recovery. And to complicate things, we did this operation whilst his wife was expecting twins, and he got down to the labor suite to see his twins delivered, and then 5 years later shook his hands and discharged him from further follow-up because he had curative surgery. Okay, I think I'll leave it at that. Gone a bit longer than I thought I would. Should we move to Q&A?